Good evening, everyone. My name is Jonathan Kaplan. I am an orthopedic foot and ankle surgeon here in Orange County, and I practice at Hoag Orthopedic Institute. First of all, thank you all for joining me this evening. I hope you're staying safe and dry, not getting wet in the rain. I want to say thank you to Hoag for sponsoring this event and coordinating it. Certainly it's a little different than our usual community talks that we're not here in person, but I appreciate you taking time to join me. So I'm here to talk about ankle arthritis, and specifically what are the latest treatments, technology, what is it that I would like you, the community, to know as far as what your options are for treating this problem. So a little bit about me. I'm originally from Chicago. I went to undergraduate school at Illinois Wesleyan University and medical school at the University of Illinois in Chicago. And then I came out here to Southern California, where I did my residency at the University of Southern California in Los Angeles County Hospital. I did my fellowship in foot and ankle surgery in Baltimore, Maryland at Mercy Medical Center. And then I came out here and joined practice at Hoag Orthopedic Institute, where I've had the honor of taking care of many great people here in Orange County. So when I thought about talking about ankle arthritis, I figured I'd start with the basics. I never want to assume that patients know everything that we know. I want to try to make it as understandable and relatable to anyone that I'm talking to. So I figured I'd start with, what is arthritis? Well, in simple terms, it's inflammation of the joint, and that can result in loss of cartilage. Okay, so what is cartilage? Well, it's the connective tissue that coats our bones and allows smooth gliding of our joints to allow us to stay active and mobile. I like to use the analogy, it's kind of like the gristle on a chicken bone, that smooth surface that allows it to move really easily. So why is it important for the ankle? Well, the ankle is made up of three bones. It's the tibia, which is your shin bone, the fibula, the bone on the outside of your ankle, and the talus, which is the bone underneath. Now, what's important to know about the ankle is that it's really supported by many ligaments, and ligaments connect bone to bone. They give you good stability. And so there's 12 different ligaments around the ankle that each have their own critical function that give you stability. Well, why does this matter? It means that there's a lot of anatomy, a lot of different things that can happen that can lead to ankle arthritis. So what does the ankle do? Well, it really moves your ankle up and down, or what we say dorsiflex, meaning you bring it up, and plantarflex, meaning your ankle goes down. There is a little side to side, but that's through a motion or a joint underneath the ankle called the subtalar joint, which is a little outside the scope of this talk, but I'm happy to talk more about that if anyone has any questions about it. So how do you tell the difference between the two? Well, a normal ankle is the picture on the left, and if you look closely, there's a nice healthy space in between the bones there, and that space is the cartilage. Well, when someone develops arthritis in the joint, you lose that space, and that cartilage goes away, and then you get bone that rubs against bone, and that leads to pain, inflammation, and stiffness, and difficulty with activities. So what do we know about ankle arthritis? Well, I'm sure a lot of you are saying, I've never heard of ankle arthritis. I know someone who has hip or knee arthritis, and maybe I have hip or knee arthritis, but why have I not heard about ankle arthritis? And that's because it's much more common to get hip and knee arthritis than it is ankle arthritis. However, what we also know is that when you get ankle arthritis, it's much more disabling. There's more disability related to it because it's much more painful. And there's actually been studies that have been able to look at how much do the levels of arthritis really affect our patients. And we found that ankle arthritis is much more disabling. It's almost equal to patients who may have end-stage kidney disease or chronic heart disease. And the reason I bring this up is that it's important to know that with any orthopedic problem, we want to know how it affects our patients and how it affects the quality of their life. And we know that ankle arthritis has a severe negative effect with that. So what are the causes of ankle arthritis? Well, going back to hip and knee arthritis, that's usually what we would call primary arthritis or idiopathic. And that just means that it happens with aging, with normal wear and tear. That's less common with the ankle. More commonly in the ankle, it's due to trauma of some sort, whether fractures like this picture here, where you can see there's a fracture up above the ankle joint, and then that changes the mechanics of the joint, and that leads to arthritis in the joint. Other causes include chronic instability. So a lot of patients will have a history of a major ankle sprain or multiple ankle sprains through their lifetime. And over time, that instability will lead to increased pressure, increased loads on the joint that wears out the joint quicker and leads to arthritis. There are some patients who will have inflammatory diseases such as rheumatoid arthritis, psoriatic arthritis, or lupus, and that can lead to ankle arthritis as well. So how does someone present, or what are the symptoms that patients will have? Well, they'll usually have pain, specifically pain with weight bearing. They may walk differently. A lot of times patients will shorten their stride so that they don't push off the ankle as much. They may rotate their leg outward so as to take pressure off the ankle. But the problem with this is over time that can actually lead to more load on the hip and the knee and affect our whole lower extremity. Also, patients will wake up feeling more stiff in the ankle as it's stiffened up while they're sleeping, and they'll oftentimes get pain at night. And this happens because as we're walking on our feet and doing more through the day, over time that inflammation slowly builds up, and by the end of the day or at night when we go to lay down, that inflammation is at its maximum point. When we examine a patient, we'll oftentimes see swelling in the ankle or the back of the foot. There'll be tender to palpation, meaning when we push on the ankle, it hurts. Patients sometimes will have decreased range of motion in the ankle. Sometimes we can actually feel spurs or bumps on the front of the ankle or the sides. We always want to look at someone's alignment to figure out if that's contributing to the problem, and we want to watch them walk because we'll notice that they're walking differently. It's always important to acknowledge the non-operative treatment because in any problem in orthopedic surgery, we tend to want to try to avoid surgery if we can. That includes modifying your activities, modifying your shoes. Oftentimes a shoe that you see here that has a roller or rocker bottom to it can help transfer the weight equally. Anti-inflammatories can help. Icing. Sometimes we'll use special braces like the one you see here to support the ankle. And on occasion, we'll use steroid injections as well. Especially with anti-inflammatories and steroid injections, it's always important to make sure there's no other medical problems that may interfere with these. And so I bring this up because it's always important to consult with your primary care doctors as well to make sure anything we're doing is safe for you, the patient. So what are the operative treatments? And that's kind of what this talk is focusing on, or what are the advancements in these treatments? Well, it kind of depends on the severity. So if someone has mild arthritis, we can do things like a cleanup, which is where we go in and we remove the spurs. That's what we call a debridement. But when it's more moderate or advanced, we have to do things that are more definitive, and that's what we're going to talk about. The selection is critical because what we do for the patient and the outcome depends on all these different factors that we're talking about. So when we talk about ankle arthritis or advanced ankle arthritis, there's really two options. You can either fuse it or you can do a joint replacement. And this is where a lot of people don't realize that there are actually joint replacements we can do for ankle arthritis, and that's kind of the latest and greatest technology. But there's still advancements for fusions, and it's important to talk about them. So for simplicity, what is a fusion? Well, that's where we go in and we take out the cartilage and we basically fuse or glue those two bones together, the tibia and the talus. It's best indicated for someone who is maybe on the younger side, someone who's less than 40 or 50 years old. And the reason this is important is because when I talk about an ankle replacement, we talk about how long it lasts. And so you have to consider the patient's age when you're deciding what to do. If someone has a severe deformity, they may be better suited for a fusion, and I'll talk about that with the ankle replacements as well. Or if someone has neuropathy or stiffness, they may be better suited to do a fusion. The benefit to a fusion is it lasts a long time. Once it's fused, it doesn't wear out. However, the downside is that you lose the motion that you have, and that alters how you walk. You can develop arthritis in those other joints around the foot and the ankle, and those can become painful. And then anytime you fuse the bones, you have to get them to fuse, and there's a risk that that doesn't happen. Traditionally, when we do a fusion, it's a very large incision. We have to use plates and screws or special hardware to hold it in place. Well, there's advancements for ankle fusions as well. The latest and greatest technology is that we can actually do this minimally invasive. We can do it either arthroscopically using small incisions in a camera like the picture you see here, and we can use screws through these small incisions to hold everything in place, or we can even use these special minimally invasive devices that allow us to really remove the cartilage with making small 2-millimeter incisions. The other thing that we've learned is to improve the likelihood of success, there's additional biology we can use. We can use patient's stem cells, whether it's PRP, which is blood that comes from the patient, or we can actually aspirate bone marrow from someone's pelvic bone and use that for the fusion as well. I'm not going to belabor this part of the talk, but the point is there's a lot of technology and biology that works in our favor to improve the likelihood of success here. More focus on this talk is ankle replacements, and my goal for this talk was really to educate everyone that there are ankle replacements and that they work great in the right patient. So what we do is we can replace the joint with two metal pieces, one for the tibia and one for the talus, and then we use a special plastic liner in between that allows motion. And the benefit here is that it maintains the patient's normal walking and normal motion. It protects those adjacent joints so you don't get arthritis there, and that it's long lasting. It can last 15 years or even longer. Now, ankle replacements have been around for a long time. They've been around really since at least the 80s and 90s. And in the 90s, there was this big uptick in the amount of ankle replacements being done. However, the problem was that our technology wasn't advanced enough for them, and there were high failure rates. And the reason was because we didn't know how to reproduce the patient's anatomy, and that's the key to success with a joint replacement. This is an example of an early model, and I showed those pictures of what the ankle joint looks like before, so you can really see the difference. That metal does not match your anatomy. It's very big, it's wide, it involves removing a lot of the patient's bone. And it works well for about 5 to 10 years, but then as it starts to wear out, it's very destructive, and we saw high failure rates. And so there's been a lot of advancements over the last 20 years, specifically the type of implants we use, the technology we use to make these and do these surgeries. So what we do is we have anatomy that matches the tibia and the talus, and we're able to remove less bone. So this is an example where we can see an arthritic ankle on the center of the screen, and on the right you can see the implant. And I want you to notice that those metal pieces are very thin, and the bottom one matches the curvature of the bone there. And so it's really trying to restore your normal motion and preserve your anatomy better. Also, we can plan even ahead of time. Our technology helps us plan for the surgery. So we can get a special CT scan that shows us your anatomy. And we get a CT scan from the knee all the way to the foot. And it shows us the alignment. It shows us the rotation of those bones, because every patient's going to have slightly different alignment. And it allows us to predict or plan for the surgery. So this is a sample report that we will get. I'll receive a 10-page report that is laying out the patient's anatomy, all the different things that are important for the success, and I can look and decide what implant might be best for the patient, what size we might use. I can also anticipate what surgical challenges or little nuances might come up during the surgery that's going to improve the patient's outcomes. Here's a part of that report. The picture on the left shows the patient's alignment. It shows how I'm going to be looking at it during surgery. On the right side, it's almost looking top down, and it shows me their rotation side to side and what are the things I need to do to make sure that their ankle is in a good straight position so that it functions well. It can also allow me to predict any potential problems during surgery. Sometimes with arthritis, patients will have cysts or weakening in the bone, and I can look at that and figure out, do I need to plan accordingly? Are there special things I need to do for that? And a lot of these patients, like I said, have previous trauma, so they may have previous fractures and surgeries. And so I can plan what hardware I need to work around and how I'm going to execute that plan. Additionally, we're using 3D printed technology, and this is a really big topic in medicine nowadays. We can take those CT scans and 3D print these guides that we use during surgery. They're sterile, they're processed in a way that preserves sterility, and we're able to use these to decrease the amount of surgical time because we can check alignment, we can ensure that everything's sitting correctly, and this saves about 30 minutes of time on surgery, and that's important because that's 30 minutes less that the patient is under anesthesia and is having surgery. That improves reproducibility. It allows us to be more accurate with the surgery, and all of these things translate to better outcomes for our patients. Also, the materials that we use are better. We're learning more and more about what types of metals work well. How do we get the bone to heal into the metal? It's a small picture, but if you look closely on this metal, you can see these little dimples. There's special coating that gets put on the metal that allows the bone to heal into it better so that it's longer lasting and it holds longer. And then the plastic liner that we use, we've learned how does that last longer. They use vitamin E infusion. The way they process it preserves it for a longer period of time. And all of these lead to a longer lasting, more stable, and more pain-free ankle that allows patients to remain active. Also, what we've learned is that anytime someone has a joint replacement, we need to have a plan for how do we go in and replace it again, because if it wears out, we want to be able to preserve that function. And going back to that first model I showed you, this is a picture on the top where someone had that surgery in the late 90s, and over time, as it wears out, some of that bone can wear out. And we need to have a way to do another ankle replacement while using the patient's bone. And so there's a lot of technology that allows us to do this, and this allows us to preserve our patient's function. So in summary, all these advancements translate to better anatomy, better planning. This better technology leads to better materials, and we have better revision options, and all of these lead to improved outcomes for our patients. If you have any questions, certainly feel free to reach out. This is my contact information. Most importantly, thank you for listening here at Hoag Orthopedic Institute. And Hoag, our goal is to get you back to you. So thank you for listening. Go ahead with questions. Perfect. Okay, so I have a question. If I had ankle arthritis, does that mean I will get arthritis in other joints in the future? That's a great question. I think that's one that I talk about with patients all the time. Ankle arthritis does not necessarily guarantee that you're going to get arthritis in other joints. It's very common to get hip or knee arthritis and lead to other arthritis. Sometimes patients will get foot arthritis in the middle of their foot or even the shoulder. The reason I separate it out is it goes back to those causes, because when someone has a primary cause of arthritis, we just know that their body is prone or susceptible to getting arthritis. With the ankle, that's not necessarily a guarantee. We do know that some people will get ankle arthritis and will also get hip or knee arthritis, but a lot of patients will only have ankle arthritis. Any other questions? Perfect. Thank you all for listening.
There's a second
I'm just going to ask you.
Yeah, that's fine.
Okay. If a patient has ligament laxity and or tendon injuries, do you also repair that?
So the question is, if a patient has ligament laxity or tendon injuries, do we also repair that? That's really important. And when we're doing an ankle replacement, during the surgery, we're actually checking the stability as well. Because if someone has ankle instability or the ligaments aren't holding as well as they should, you have to address the ligaments and balance them out. Meaning I will oftentimes repair the ligaments to give better stability as well. Going off of that, sometimes a question I'll get asked is, if I have ankle instability or laxity, but I don't have ankle arthritis yet, do I need to address my laxity? That's a harder question to answer because we can't predict the future, of course, and not every patient who has ankle instability or sprains is guaranteed to develop arthritis later. So the best indication to address the ligaments before developing ankle arthritis is if it's severe instability where patients are having repetitive sprains. If you sprain your ankle every year or a few times a year and you continue to do it even with minor missteps, then oftentimes it may be beneficial to repair them. However, otherwise we go based on how it affects the patient. So another question, how about PRP injections and stem cell therapy in place of ankle replacement? Another great question. I think this is important and it's something I talk to patients about all the time. I do think that this is an option. Part of the reason I didn't address it in the talk is it's a whole nother talk in itself. But I do think that PRP, and for our listeners what PRP is, it's called platelet-rich plasma, meaning our body has circulating growth factors and healing cells that are used to heal the body. The best analogy I give is when someone sprains their ankle, it gets swollen and inflamed, that's the body's way of bringing those healing cells to that area to heal it. So we can take a vial of blood and isolate those cells and then inject them into the problematic area. There are good studies that show that there's benefits of PRP injections with ankle arthritis in regards to pain relief. We can't quantify if it's healing the cartilage or not, but we look at pain relief, and there are studies that have showed that PRP does help improve patients' pain. So I do think there's a value there. The downside to PRP is purely the cost because it's not covered by insurance. And so it's something that I offer to our patients, and I let the patients decide whether or not to do that. Stem cell injections are cells that are harvested from a placenta or an umbilical cord and processed in a certain way. They're not true living cells, but they're these growth factors as well. And there are some studies that suggest maybe they help relieve pain as well. So I do think it's important to discuss with patients, and at the end of the day, it's ultimately up to the patient and how much they want to do before doing anything invasive like a surgery. Another question, do you still do microfracture treatment for more than 15 millimeters of a chondral lesion, and what is your recommendation? So to give our listeners insight, when patients will have different types of cartilage problems, one of which is an osteochondral defect. So arthritis is when all the cartilage wears out, the whole surface or a large portion of the surface wears out. Sometimes a very small surface area will have wear and tear or an injury where the cartilage is missing. And in those cases, you can do different things to try to repair or salvage the cartilage. Usually a microfracture is where we either scrape the bone or we drill into it to stimulate healing from the bone itself. Now that's best indicated on smaller lesions, meaning when they're less than 10 to 15 millimeters. The ones that are larger, we've moved a little bit away from that. We still do that, but there's this growing belief and there's more technology that's looking at how do we resurface it. So what we'll do is we'll go in and we'll microfracture it, but we can also use either cartilage that comes from a cadaver, or we can use patient's cartilage from another part of the body to resurface that area on those larger defects. And that's important. The size matters there. What are the pros and cons of a fusion? So when I talk to patients about ankle arthritis, I go over both ankle fusions and ankle replacements because at the end of the day, there's pros and cons to both of them, and it's really important for the patient to choose what they're most comfortable based on those pros and cons. The benefit to a fusion is that once the ankle joint is fused, it's not going to unfuse. It doesn't wear out. So when we do an ankle replacement, we talk about how it can wear out over time. Well, a fusion won't do that. And so once it's fused, it's not failing. The other thing is that when it's fused, it's pain-free. We know that patients who have an ankle fusion, they're happy because their ankle doesn't hurt anymore and they're able to be active. You still have some up and down motion through part of the foot, and so you don't lose all of that motion. The cons to the fusion are we know that over 10 to 15 years, a large percentage of patients will develop arthritis in the joint underneath the ankle, the subtalar joint. And so I warn my patients that you may feel great for 10 or 15 years, but then as you develop arthritis in this other joint, it might start to hurt. And just like ankles, you might need treatments for that. You might need non-operative or operative treatments. The other con to a fusion is that we do know that it does change how you walk slightly. You can't quite roll off your foot as much, you don't toe off as much. And so when we look at studies in labs where we watch people walk, we know that when people have an ankle replacement, they walk a little bit more naturally. But at the same time, that doesn't mean patients can't walk and they can't be active. We know that a lot of patients with ankle fusions, they can walk, they can hike, they can work. We do fusions on a lot of laborers. If someone in their 20s or 30s and they're construction workers develop arthritis, we're going to recommend a fusion because it's long lasting and those patients can get back to work. So just because you lose that motion doesn't mean you can't still be active. I think the key to understand is that you just have a risk of developing arthritis in the joint underneath the ankle down the road. Patient has been advised for a fusion over a replacement. I just turned 56. This will be my second surgery in 2 years. Well, I think this is where it's important because every patient's a little different. And when we evaluate patients, we want to look at what is the patient's age, what is their activity level, what is their alignment. We want to look at how much motion do they have, where is their pain, what are their goals for activities. Someone at 56 technically is a candidate for an ankle fusion, and they're also technically a candidate for an ankle replacement. So it depends on some of those other factors. For me, an absolute reason not to do an ankle replacement is someone who's younger than 50 years old, just because we worry that it might not last long enough. If someone has a severe deformity where they're really excessively tilted in or excessively tilted out, that we can't totally correct through an ankle replacement, but a mild to moderate deformity you can correct. Patients who smoke cigarettes or who have poorly controlled diabetes, we usually do not recommend an ankle replacement, although at the same time we usually don't recommend a fusion until we get better control of those. And then there's a few other things, like if someone has neuropathy, then we might recommend a fusion over an ankle replacement. But with the information of just a 56-year-old, technically you could do either or. It just depends on a lot of factors. And hopefully this talk has helped give some insight into that. Perfect. Thank you very much. If there's any questions, do not hesitate to reach out. I appreciate everyone for taking time again to join us on this rainy evening.